Hi, my name's Rusty and I'm here this morning to talk about endotracheal intubation. I'm going to do a demonstration while talking through the whole procedure, and here we believe slow is smooth and smooth is fast. So first what we're going to do is take our stethoscope and put it around our neck so we can find it when it's time to auscultate for breath sounds. First we'll determine that our patient is apneic. So and all that entails is, hey, are you okay? You look for chest rise and fall, listen for air exchange, and feel for any breaths on your cheek, and there are none. I suspect no trauma, so we're just going to do a head tilt, chin lift to open the airway. Then I'm going to get a oropharyngeal airway, measure it from the tip of the ear to the corner of the mouth, insert it upside down to go to the hard palate. Once we get to the soft palate, we're going to twist it 180 degrees and insert it. Get our BVM, place it over the nose and mouth, get a nice C-E clamp, and begin to ventilate. This is only on room air, and at this point, while the student is ventilating once every 5 to 6 seconds, or 10 to 12 times a minute, they will receive the prompt from the instructor that their O2 sat is 85%, and they'll need to verbalize they are hooking up the BVM to 100% O2. At this point in time, I'm going to pass off the responsibility of ventilations to an assistant. I will instruct them to bag once every 5 to 6 seconds while I check out my equipment. I'll secure the laryngoscope handle and the blade and make sure that connection is tight, and then turn it on and make sure that the light is tight, also that it is bright and our batteries are good, and that it is white. So key terms there is tight, bright, and white for the laryngoscope handle and blade. We're going to leave that on the left side of the patient, and then I'll check out my ET tube. We'll get a 10 cc syringe, pull it back to 10 cc's, open up the package, put 10 cc's of air in our endotracheal tube, and remove. You have to remove the syringe at this point to make sure the seal on the ET tube is complete. This bulb is inflated, and the bulb on the end of the ET tube is inflated. Then you can take that 10 cc's out and leave it attached at this point in time. Then an important thing to have is a stylet. The stiffer the stylet, the better. It maintains the shape of your ET tube in the airway. And an important consideration is make sure the end of the stylet does not go past the end of the ET tube. At this point in time, the equipment is ready. I'm going to take this out, maintaining as clean as possible ET tube, and prep my handle. Handle's in the left hand, ET tube's in the right. On the count of 3, I'm going to have my help stop ventilating the patient and remove the oropharyngeal airway. 1, 2, 3. Stop bagging, move it. You have 30 seconds. With the curved blade, you're going to sweep from left or from right to left, lifting up, visualize the cords, insert it, put the handle down, turn off the light, hold the valve right here, inflate, pull syringe off, pull that out, and have him start to ventilate. Hopefully you see, if you're successful, rise and fall of the chest. We're going to auscultate the epigastric area first to make sure there's no air in the belly and it's negative. Right side, clear breath sounds. Left side, clear breath sounds. And right now we're in place. We can also observe for misting in the tube, and then we'll get our colorimetric device out. So with no CO2 present, it is purple. and with CO2 present, it'll turn yellow. So the memory jogger there is Barney is bad and Big Bird's good. At this point in time, we'll secure our tube with the commercial tube tamer. To secure it in place. At this point in time, the student will receive a prompt from the instructor that they hear gurgling and they see secretions in the tube. That's the prompt to suction, deep suction the endotracheal tube. We will get a flexible suction device and measure it. The preferred method is to measure it against a like-sized tube. We'll mark it with our finger or a piece of tape, or note the measurement on some tubes. Then at this point in time, I will instruct my assistant to remove the colorimetric device. I will insert the suction cath into the airway and then apply suction on the way out and have him ventilate again. If there's a lot of secretions, we can remove it by suctioning into some normal saline. And then we ventilate our intubated patient once every 5 to 6 seconds or 10 to 12 times a minute. Thank you for your attention. Have a good day.